event X number of years ago has sort of propagated itself. So I thought this is an interesting example. So um, that was in the pre-1990s. EMR started to come around in the 1990s to 2000s. Open notes as a movement is an interesting movement. 2010, Harborview is one of the first sites where we actually gave patients access to their notes, and we found they were more engaged and seemed to have more effective care when we showed them their notes. So creating more of a collaborative relationship with patients. We started doing more open notes work in 2014, and then the 2021 21st Century Cures Act mandated that we couldn't block notes from patients. So as soon as it's available for us as clinicians, more or less we're releasing it in real time as soon as that visit is signed. So as soon as we complete that visit, patients can now read it. So now the audiences are not just the insurance company and the billers, it is also inclusive of the patients. As we mentioned, it is a requirement, and I can assure you that patients are reading it, maybe not at the rates you might be thinking they are, but certainly patients are reading their notes. And in fact, there's a button now in my chart where you can ask for a correction in line right at the time of reading their note. So patients are asking for corrections. So we wanted to start with a bit of framework and evidence around how, what we think when we think about bias being entered into notes and propagating, similar to that example we shared with Elaine from Seinfeld. So the patient comes to see me. I'll use myself as the guinea pig here. And I might see that patient and I might have certain feelings, conscious or unconscious, intentional or unintentional, about how I perceive this patient. They might be upset that they've been waiting for an hour and they are presenting themselves in a fashion that I would be tempted to label them in a certain way. I include that in my note because, hey, I'm just writing that in the general section of my physical exam, that this patient was speaking loudly and was agitated. But then they go and see Dr. Martin next, and he says, maybe this patient isn't the easiest patient to work with. I need to be a little bit thoughtful about this. But now you're starting off from a place of bias. Your next note has that as your starting point. That's your anchoring bias. And you can sort of imagine the circle continuing, that every person you see, increasingly that sort of effect gets labeled over and over and over again. You can imagine that as we move into an era of artificial intelligence, as we start to summarize notes, that becomes a source of truth to the computer, who can't separate maybe one moment of perception from perhaps a pattern where you have other evidence and data points to suggest that this may not be a true statement. So what if we were to introduce negative language into this? So remember that bias can be positive. We might give people a pass and speak extra positively about certain people and less positively about other people. And so this is focusing on negative language. So if I were to speak in words that had negative connotations or introducing bias, that note then becomes biased, such that when Livingston reads my note, he might be starting off with that bias and is at risk of providing biased treatment. You might not treat the pain as much. You might not care to send them to the same referrals that you would otherwise because, hey, they may just not show up because that's something that they don't do as effectively when they come to see you in primary care. And as this cycle sort of repeats, we really want to think about, how do you consciously break this cycle? How do we offer feedback, both at the practicing clinician level and at the educational level? How do we teach our next generation to be thoughtful about interrupting this cycle of potential biased language? We're not just making this up. There are studies that have been done. So these are some of the studies that exist that speak to each arm of this cycle. And we're going to cover some of these in detail. So Dr. Martin here will talk about some of the evidence that suggests that, in fact, once you introduce bias, that it affects the care that they may ultimately receive as patients. So we'll start with that first leg here.
Right. So the first study we wanted to highlight was this one by Park et al. It's a qualitative study looking at 600 randomly generated internal medicine notes. And this is intending to categorize language based on positive or negative attitude to the patient. And they ultimately identified these domains, which they described as positive language, approval, bilateral decisions, compliments, attempts to add personalization details to the note, self-disclosure, and minimizing blame. This is the way they categorized it. I know this is sort of a busy slide, but I do like the way that they're calling out these definitions. So, for example, the approval name is defined as highlighting patient knowledge, character, reasoning skills, and self-care patient behaviors. And in particular, the examples here are pretty helpful. So this is an example of the approval category, stating that she has a physical, mental robustness that belies her age. She remembers both recent and distant events and is enjoyable to converse with on many subjects. So these are examples of that domain of positive language in clinical documentation. And then another category is minimizing blame. All of these are great, but I'm just highlighting 3 for the purposes of this talk. This is reporting, sort of explaining reduced patient capacity or unhealthy behaviors in a patient-centered way that conveys understanding of the condition and minimizes blame. So an example of that would be she has not been checking her morning glucose for a month because she lost her glucose monitor, sort of an explanation of this. And then the bilateral decision making is references to the incorporation of patient preference in addition to provider preferences in the treatment plan. So an example would be she stated that even if it was positive, she would not want further testing. She will think about this and let me know next time if she wishes to proceed. And I do want to make a comment. It's not saying you should incorporate a bunch of positive things and not negative things. Positive language can also be problematic if it is incorporated in a way that is not equitable. So if you're always adding positive language for one type of patient and not for another type of patient, that's also another domain of bias. So the takeaway is not to include more positive language, include less negative. It's be cautious and mindful of all of this. So next slide is not going. Let's see. Uh-oh, it's frozen. Okay. So some negative language categories would be disapproval, questioning credibility, as well as unilateral decisions, stereotyping, and classifying the patient as difficult. So now these categories are described here. So the question credibility is implication of physician disbelief of patient reported experiences, of their own experiences or behaviors. So an example of this would be writing. I listed several fictitious medication names, and she reported she was taking them, and that she takes, quote, whatever is written there. So the purpose of that quote is to express physician disbelief as opposed to sort of representing the patient perspective. So an example of disapproval is highlighting poor reasoning, decision making, or self-care in a way that conveys that the patient is unreasonable. For example, he is adamant that he does not have prostate cancer because his bowels are working fine. Counsel that there's no evidence of this, but the patient has strong beliefs. That's an example of that. And then difficult patient, that's inclusion of details or of questionable clinical significance that depict the patient as belligerent or otherwise suggest the physician is annoyed. And an example would be, I informed her that this is unlikely to be helped by antibiotics and talked about smoking cessation with her. She said she'll ask her sinus doctor for antibiotics. And I included these so you can also look at them afterward as well. They're good categories. So the problem is that incorporates the perspective of the note writer into the note. And so you've now incorporated some of these biases into the note that then is going to influence a future reader. So now we'll talk about what that looks like. There's another study by Godot et al. This is evaluating, so what? So the tone and the wording was not great. How does that actually affect clinical care? Well, according to this study, it does affect clinical care, in this case, pain management intensity, as well as physician attitude toward the patient. And so here's an example of 2 things that communicate the same general information, but are written in different ways. So one is Mr. R is sleeping, but easily arousable and seems distressed. He is not tolerating the oxygen mask and still has 10 out of 10 pain. His girlfriend is by his side, but will need to go home soon. Now, another way of writing essentially the same general information is Mr. R is sleeping but easily arousable and has been cussing at the nurse. He refuses to wear his oxygen mask and is insisting that his pain is, quote, still a 10. His girlfriend is lying on the bed with shoes on and requests a bus token to go home. So with these 2 phrases, the one on the left is written in a more neutral tone, whereas the one on the right has the potential to incorporate some stigmatizing bias to the future reader. And so how does this affect patient care? Well, this study indicated that based on this scoring system, that if people read the more neutral language, version, then they have more positive attitudes about the patient as opposed to the one with stigmatizing language, which is closer to the more negative attitudes about the patient. And that resulted in changes in the way pain management was done. So the neutral language resulted in more aggressive pain management, whereas the stigmatizing language version resulted in less aggressive pain management. So there's another study by Mamade et al., which is exploring the hypothesis of how does provider emotions affect clinical reasoning and the ability to effectively deliver care. So here's a couple examples. So the last patient of the day is a 32-year-old woman, patient of a colleague, insists against the colleague's opinion that she should be referred to a specialist. The patient says her problem is too complex to be solved by a GP who only prescribes paracetamol. And another way of saying it is the last patient of the day is blank, a 32-year-old woman, a patient of a colleague, but he had asked you to see a patient today. The patient's medical history includes. So by including the word insists and the information about against a colleague's opinion, and then the quotation of who only prescribes paracetamol, that is indicating to the reader that this is a difficult patient. It's just not writing that word, but it's indicating that this is a challenging type of encounter. And when you include markers in the language that the patient is difficult, according to this study, a provider is less likely to arrive at the correct diagnosis. They're more likely to recall the behaviors that were described in the note, and they're also less likely to recall some specific clinical findings associated with it. There's lots of other studies, but those are the three we highlighted at the moment.
I'm going to go back to this real quick. I think this is just taking a second to reflect on this slide is important. If you write something in a certain way and you read, somebody's written it, so I've written it and Dr. Martin here is looking at it, he's more likely to remember the story, right? It's like story time. He's more likely to remember the story of how that patient was behaving, less likely to get to the right diagnosis, and less likely to remember the clinical findings. So you're really just going to remember the behaviors and not actually any of the stuff that you're supposed to be doing. So your neutrality is very much being challenged in that moment. So when we talk about this is an English class, when you write notes, this is to a degree saying that in different words, which is the more narrative you have that's not neutral, the more risky you are where that patient's actually not going to get the care that they need. So we're going to go through some examples. Some of this is, of course, stuff that maybe you've reflected on this. I certainly found myself writing in certain ways. So I wanted to just share some examples. Many of these slides that we've shown you so far are courtesy of Dr. Wong and Dr. Jackson, the co-editors of that book. We've modified these somewhat, but these examples are in large part things that they've shared in their talks they've given as well. So the example of the patient refuses labs. I certainly, when I started my training, would write this patient refuses blank. And the choice of refuses made me think. I remember like meeting with somebody and they said, I didn't refuse that. What are you talking about? I just said no. And sort of it adds an unnecessary, to me, level of declination where it's not just I said no, it's I compassionately said no, I refuse this. Under no circumstances will I go get that lab, right? I mean, that's not really how the vast majority of patients are acting. So the question is sort of, is refuses the right word? Could you just be more benign and say decline? You might also explain why, as we talked about earlier, they decline this because they are concerned that this is not actually going to help them arrive at the final diagnosis, or they're going to check with their insurance first before they randomly get the test that you're telling them to get. So I think some explanation can be valuable versus just straight up saying, no, they refused it. I'll say that in our SGOH screening at UW and EPIC, when we have we ask them questions about social drivers, the default out of EPIC for a long time is patient refused. And it might just be saying, patient just said, maybe not today, And so sometimes this language is built into the systems and isn't even something that we always have control over. Patient's been non-compliant. I had somebody once tell me metals are something that comply or don't comply, but not people. So, we talk more about adherence. So saying you're non-compliant is sort of applying a judgment phrase. Whether we're choosing or not, intentional or unintentional, the reader will view it with a labeling effect. So thinking about why you might say adherence rather than necessarily compliance. And this slide is good to say that people can choose to make decisions that we objectively feel are good for them, they're also allowed to make decisions that we objectively feel are quote unquote bad for them. The behavioral economics of why people decide what they choose to do isn't really our business to say, we're here to tell you what you should do. We're here to work with you and partner with you and recognize that you understand the risks and benefits of making decision A and decision B, but ultimately there may be variables that we aren't aware of or that they may not choose to disclose to us that might have them make a quote unquote bad decision. I'm not going to take my certain diabetes medication, although we recognize that they're having side effects or complications from diabetes if it's going undertreated or untreated. But the idea of adherence allows us to be a little bit more neutral in our wording rather than just saying they're being non-compliant, they're not taking the medications. This is an example you heard about earlier. Adamant he doesn't have prostate cancers because, quote unquote, his bowels are working fine. Now, we know that when we read this, this is implying that this patient doesn't understand that the prostate and your bowel habits aren't necessarily related. It's just sort of indicating a patient miseducation point. And so there's a couple points here. Adamant, um, they might sort of be repeating themselves. So in some cases, it may be true that they are adamant, but the implication when I read it is this patient wasn't being rational. They didn't understand it. And by adding the quotes, I'm saying, yeah, they're just not that smart when it comes to their health. That's the implication here. So being mindful about when you use quotes and how you use quotes, is it actually substantively improving the HPI, or is it just trying to indicate that, hey, maybe this patient, you need to explain to them because they don't really understand things. They claim that nicotine patches don't work for them. Claiming is a good one. There's another one I think that I say states, but claiming is like, I like when I talk to people who are in law and they say that the person alleges, it's alleged, and they claim. It feels very legal-esque. And for some reason in medicine, the idea of claiming is sort of not attributing that it is or it isn't. It's just, well, I don't know if I believe this person. They're claiming that it doesn't hurt. They're claiming that this medicine doesn't work for them. And how many times do we get a diagnosis on an MRI that they claimed was something that we didn't believe them on? Insists that she gets sick from vaccines. You know, you get I don't get the flu vaccine because it makes me sick. I swear I don't want the flu vaccine. I always get the flu after I get the flu vaccine. So just understanding what you're communicating when you choose certain language, when you talk about insisting. This is one of my favorite ones, denies. Same thing. I had a friend of mine who said, I didn't deny that. I just said no. I didn't have chest pain. I didn't. And they just kind of chuckled to themselves about how we say the word denies. So I've started saying has no chest pain, has no shortness of breath. Because that is, in fact, we have to either believe the patient or not. It's not that they're denying a certain piece or not. The last piece beyond the examples is sort of a piece that was alluded to earlier. It's not just that the language exists. You know, it's not like you're an equal opportunity hater. It's that you're not an equal opportunity negative language includer. You're really including this sometimes more often for certain patient populations than others. And there's also data to support that. So this is a study in which about 600 notes were analyzed for the concepts of doubt and disbelief, and talking about what it looks like, you know, what kinds of themes are included in language that might suggest something is being dismissed or ignored. And these authors identified 3 themes. So the first they describe as evidentials. So patient states that versus patient does not use. Is sort of saying, I'm not sure I believe them, but they're saying this, so I'm just going to say that they're saying this. Judgment words, so insists or we claim, is sort of instilling a seedling of doubt that maybe it's not actually true. And then quotations, if used in certain ways, particularly, can say, hey, the COVID vaccine is poison, instead of saying that the patient has concerns about COVID vaccine. By putting in the quotes, you're not actually just doing the due diligence of using their words, which sometimes feels like I'm being patient-centered. It's, in fact, instilling some element of doubt. So when they looked at this and they looked at the identities of the patients, they found that in the case of race, black versus white identified patients, and this N is over 9,000 notes, that you are more likely to find certain words used in certain patient populations compared to others. On the bottom, they also looked at female versus male identified patients in the study, and you can see there may not have been difference in some of the categories, but there was in the quotations piece. the key point here is that the words aren't always apportioned the same exact way for every single patient that you see. And to Livingston's point earlier, it's not just we're saying use positive language. It's really the idea of being mindful of having consistency and neutrality as much as possible across all your patients rather than sort of letting societal or otherwise unrecognized biases infiltrate into your notes as much as possible. So you didn't just invite us to talk about notes. You invited two clinical informaticists to come and talk to you because you really wanted to think about what is the opportunity and where does informatics and AI fit into this puzzle. So I'll turn it to Dr. Martin here to take us onto this final topic.
All right. So a couple major concepts I want to describe real quick. So the first is what are some of the roles of AI in trying to address this and reduce harmful language? One concept is called NLP, or natural language processing. So UW has a definition. There's a AI glossary. And so I took these. There's lots of definitions floating out there, but these are the UW definitions from the glossary. So this natural language processing is the subfield of computer science that's focused on developing computer systems, the ability to generate and interpret text and spoken words, right? And so why is NLP going potentially helpful for reducing harmful language? Well, it can detect bias categories. And so detecting things that are classified as negative, tone, labeling, doubt, that sort of process is done with natural language processing. All right, so now large language models, you're familiar with these. These are the ChatGPTs and Geminis of the world. So these are, this is UW's definition. Essentially, they're a large neural network that's trained on a vast amount of information with the goal of trying to predict the next word in a sequence of words. So the most important thing to know about large language models is they have no inherent knowledge of truth. They're just making a statistical prediction of what's the next most likely word after you've replied with a word. And this is often very good at answering questions because often the answer is the right words clumped together, but it also is not sometimes, and that can be really problematic. And so LLMs in general can help with note writing in a large number of ways. One is by generating feedback, suggesting rewording, changing the pattern of words, processing natural language, and they're being explored in many, many domains at the time. We just came back from the EPIC expert groups meeting last week, as recently, and then I think maybe it was the week before. Anyway, so they are working on a functionality called destigmatize, where you basically select patterns of text and you right-click it, and then you send it to a LLM in EPIC directly to remove some of these markers of bias. But I don't know how it's identifying those markers. That wasn't described. They just demoed the feature without describing it.
Natalie. Natalie.
I'm sorry, I'm hearing something. Oh, okay. Sorry. Someone came off mute. I thought there was a question. If there's a question, feel free to ask. All right, and then the third concept I want to address is called RAG, or retrieval augmented generation. So RAG is basically a way of optimizing the output of a large language model by having it reference an authoritative knowledge base that's outside of its training data before it generates a response. And that's a pretty core concept because, like I said, the LLM is just guessing at the next most likely word, whereas RAG can find a authoritative, peer-reviewed source of truth that then informs the response. And so the way it helps with note writing is it'll anchor any suggestions from the LLM in a validated source of truth, and ideally one that's supported by the literature in order to ensure accuracy and currency. And so I have a picture to describe this. And so essentially, RAG works by a user submitting a query, like a prompt query, to a retriever. The retriever then searches for relevant text in a data source, and then it replies with the query, the original query, plus whatever it found from its source of truth to the large language model, which then generates a response using that process of predicting the next most likely word in a series of words. And I have an example that I like, that how many moons does Jupiter have? And so if you were to ask me, and I'm just a regular large language model, how many moons does Jupiter have? You've ask me, and I'm going to generate a response. And I'm vaguely recalling that Jupiter has 20 moons. I think I saw a Reddit post in 2003, and I don't know how to cite my sources. I just know that that's the most popular combination of words. And so I tell you, oh, Jupiter has 20 moons. And I'm very confident in my assertion, but I'm also very wrong. And so the right way to find out the number of moons that Jupiter has is to use something like a RAG. So you ask the query, and now the retriever is going to go find a validated data source. In this case, I chose NASA, so I'm pointing it to NASA. And I query NASA and say, so how many moons does Jupiter have? And they're like, well, the International Astronomical Union says there's 95 moons. And so now I'm able to reply with the query, now backed up by hard data to the LLM, and I've given you the correct response of there is 95 moons of Jupiter. And counting, they keep finding more moons. So future opportunities. This is a quick preview of some of the work that we worked on. This was a team effort, not myself alone, and really, really helpful. Long story short, we evaluated a way of putting together some of the literature recommendations for patient-centered note writing in a rubric that would ultimately be able to be used by a large language model with that RAG setup in order to provide good evidence-based feedback on how to assess language and recommend improvements to remove biases. Here is some of the categories that were supported by the literature. You'll notice some of the categories align with one of the studies, the PARC study, but there are other studies that influence this. This is a proof of concept. It does not been validated on a wider data set, so don't take this as truth and run with it yet. We used a have not tested it on enough notes in order to know that it's accurate yet. Here's an example of what labeling would look like. So you basically diagram sentences and identify elements within the sentence and categorize those elements. So for example, these are useful descriptors that may influence the course of treatment because you have more context when you're helping treat the patient, whereas describing polysubstance abuse and medical noncompliance may not necessarily help that interaction. Also, specifying multiple complaints maybe is not as helpful. And here's a couple annotation categories. These are, I'm not going to show all the elements of the rubric, but there are different ways of classifying language into these categories of negative language, positive language, the concept of labeling, which is assigning the patient to a named category, and then quotations and other language marking. So the future state, we essentially just want to make clinical documentation practices align better with UW medicine values. And so these are UW medicine values, and we want to make sure that we're having our clinical documentation reflect that. And we want it to be sort of easy and seamless and something integrated in the system to help us have our notes communicate critical information in a patient-centered way. And I also included a QR code that links to this book. There's a website to this book, so if you want to scan that, I found this as an incredibly helpful resource that summarized a lot of the key findings in the literature. And so if you're going to read one source, it would be that book, in my opinion. All right.
So we also think like a next step, like imagine you're a medical student or a resident, and you as the attending want to give feedback to this student or this trainee. And as a first pass, if we could feed it all sorts of different components, patient-centered note writing, you can imagine what we talked about, like hypertension control. We gave it the latest and greatest in hypertension control and said, how is this working for hypertension control? But patient-centered notes is something that is a little bit harder because it's more of the subjective versus the objective in medicine. But I think these kind of efforts is where we think there's an interesting future where we're not just saying like you have to record every visit and do that. But if I, at the time of writing my note, was able to get an initial pass of, hey, reconsider these language pieces, or maybe here's your pre and your post of how you could reword this, it might offer a little bit more of real-time feedback in the moment at the time you're writing it that honestly would be helpful for all of us, but really is part of the educational process. We think this could be really value add. And I know at the department fair, there was Larry AI that was mentioned by Dr. Keane and Dr. Bennett. the idea of building on Dr. Larry Mauch's work around patient-centered communication. And so that was taking the transcript of a visit and then offering ways of improving the verbal communication patterns. This would be a similar theoretical idea where you could offer feedback based on written communication patterns to think about if a patient were to read this note, how would you make it so that you recognize that there is medicalese, but it's meant to be objective medicalese, not necessarily just for the sake of writing it to express doubt or have other concerning signs. So we would love to answer any questions you have, opening discussion. We wanted to fly through this. We are a little ahead of schedule, when we had a little bit late start here, but happy to take any questions or thoughts or ideate with you about how this might be able to be applied in the future.
Thank you so much for that. We don't have any questions in the chat, so happy to take anything in the room. I'm just sort of thinking about reflecting on the culture of medicine and the culture we enter into as we start in medicine, and it does feel like that's something that we don't come to necessarily to, but it is a culture, and so be interesting to look at that in terms of systems and how language develops in a culture. And I think those are really interesting questions, and glad that technology could sort of help us as we're thinking through that. To that point, I'm part of the Abridge pilot where it's helping, it's a note writing platform that we're using. I'm wondering if there's anything coming out of Abridge that is looking at that specifically around language modification and how we communicate in our notes.
Thanks, Nina. For those in the room or on Zoom, so I am one of the co-leaders of our Abridge pilot. So Abridge is a software company that we've partnered with in a pilot fashion at UW. It is using ambient listening, ambient AI technology, where you put a listening device in the patient room with the patient's consent. It listens to the visit, creates an audio transcript, and then summarizes it and writes your draft of your provider note for you. So it gives you a really nice starting point, but now you no longer are the primary author, you're instead a primary editor of the work. So to your point, it is both an exciting opportunity where you could introduce some of the best practices into, I'll give you a simple example that's not bias related, but different. There are some written no-nos, like where you put decimal points or whether you put 0.5 or 0.5 to make sure that prescription dosing isn't confusing. And when I was looking at one of my notes, one of these no-nos was included in my draft. And so I was able to give feedback to say, hey, there is a Joint Commission and many other sources that tell you when you write prescriptions, do not have these no-nos in there. And it would be very easy just to introduce that into the model for them and say, hey, we actually don't want this, respect this to the RAG opportunity. We now have a source of truth. Just use the source of truth whenever you're writing your notes. And so what's an opportunity is that we could introduce those types of sources and say, hey, these are best practices. Introduce this. When you're writing this, consider this. What we have seen is generally it's favorable when we're seeing the note output. There are some evidence. I often see like quotations as a common practice that it provides, but I haven't found it to be necessarily in a dismissive tone. It has usually, I'm always like, because of my work on the book, I'm always a little bit extra critical to think about it, but I haven't found it to be very inappropriate in how it does that. The challenge for us is that increasingly in medicine, we are further and further away from the root of the work. We are now hiring a third-party company and hoping for them to take this as seriously as we take it ourselves, and our locus of control has become increasingly further and further away. I think that's the risk that we have, but I will say that to Epic's credit, the idea of being able to select a body of text and right-click and hit destigmatize shows that the technology is there. It's very easy to do. It's just a matter of prioritizing it. So now the piece is really making the case for why this is the right thing to do, and that's going to be the next challenge in this area, I think. Any thoughts you want to add? Christina's in the room. I'll bring the mic to you, Christina.
Thanks. Thank you for your work. It's really interesting. I guess my question is sort of philosophical, and I'm not really sure actually how to word it. But I'm just thinking about how the words reflect the attitude of the physician who's in the room, so that if you have a physician with a negative attitude, it's going to produce negative notes. But if you have a physician that has a positive attitude, would that positivity be reflected in the notes too? And then I sort of wonder, could it work backwards? If you're trying to use destigmatizing language, whether that can actually work sort of backwards to create a more open-minded physician. I don't know if I'm making myself very clear, but I'm sort of concerned too that the notes may be destigmatized, but the provision of care may not be destigmatized. I don't know if you have any comments on that.
That's a really great comment, and you're right. There's a lot of efforts in order to reduce bias and stigmatization from providers. But the advantage with adjusting the language of the notes is you can sort of interrupt that cycle of whatever is written during that encounter propagating within the medical chart and affecting other providers. And so, yeah, you're right. It may not necessarily change that one person's opinion, or it might, because they saw, oh yeah, I wrote it this way and it's recommending I change it. Perhaps that's a little moment of feedback as well. You'd also be able to use the same thing as a teaching tool to automatically grade notes, assign scores of whether notes have higher levels of bias based on validated rubrics, and then you can use that as a conversation tool with providers as well, to say, oh yeah, your notes are pretty aggressive sometimes, and these are why. This is exactly why, and so it's flagging on these elements of these sentences with these words, and so you get a little more granular than just saying, oh yeah, your notes should be better. Well, why? What do you actually change? What specific elements would make this note effective in communicating critical medical information clearly, succinctly, and without causing these extraneous, potentially harmful effects? So it's a little long-winded, sorry, but that's my thoughts.
And I think we're not under any impression that we're solving bias, right? But what we saw from the literature is that when you read a note, when I read a note, if it's starting off with a certain expectation, it's really hard to break from that anchoring point. And so the less we can continue that cycle, you look at like family medicine service, the patient's been like, there's sort of like this thing where the longer the patient is there, the more you have an opinion about it. And so it's similar where if every day you sort of came in and sort of said, have a fresh set of eyes, it allows you to reassess the situation and say, is this really in fact what is the truth, or is this something that I was just sort of expected to think because this history of issues has been coming up? I remember, for example, one of my residency colleagues, Dave Siebert, shout out to Dave. At the end of our residency, there was a patient who had chronic abdominal pain and just had been ignored by everybody. And somehow Dave, he's an incredible doctor, said, you know what I'm going to do? I'm going to test for hemochromatosis. Just throw it out there. Patient comes back flagrantly positive, figures out the whole diagnosis, and basically takes all of this history of notes that told him he should just tell this patient, you have a chronic abdominal pain and you should move on, and you should do all these things to mitigate your symptoms. But instead, taking a fresh eye, fresh set of thinking to it, lets you sort of get back to the correct diagnosis. So for whatever it's worth, the story here I'm getting out of it is, if I start from a place of neutrality, I'm more likely to be more neutral in making sure I do what's right. The heuristics of taking shortcuts, I'm more likely to avoid. If I have positive language, the risk becomes that I'll be more likely to refill this medication that's controlled. I'm more likely to give it a pass or let this patient have more no-shows because I have other reasons to be okay with it. And if they have negative language, then I'm more likely to be harsher against that patient in my care and my treatment. And that's what we hear about is X community has certain care, Y community has different care. But what are we doing to potentially interrupt that cycle? It's not just because we have to walk in and be completely unbiased. The language that has kind of gotten us to this point is probably the first step that we actually have control over. I can't control the whole system, but I can control what I choose to write. So to me, that's allowing me to take some element of change to it versus just sitting there and saying the system is broken, the system is broken. This is the one aspect that I 100% can control.
I had a question. My name is Erin, and I am a medical assistant, so definitely don't have the knowledge and information that many of you do. But one thing that I was curious about is in regarding, making specific annotations to either inform the next potential person, or even though we're using this mostly in chart notes, is there similar systems that would be used for, I think they are like the CLPNs and precautions that are to be mindful of for the patient for interactions? And how can we utilize the systems that we have with via Bridge, as well as what you were just referring to be able to provide insight, protecting the patient as well as those that would be interacting with the patients?
Just to clarify the question, so what I'm hearing is about in our electronic health record, we have care plans, and sometimes patients have shown behaviors of violence, and we want to make sure we protect ourselves and protect the patient from hurting themselves or others. And so sometimes when you apply a care plan, it's very easy to border away into stigmatizing language because inherently we have feelings and opinions about somebody potentially affecting the safety of our colleagues. And so I think that the fine line that I've observed, that's hard for me, I'll admit it, is that like it's tempting to just not be medically accurate in this for the sake of trying to be more neutral. And so there's a difference between objective and accurate. So like obesity, for better or for worse, is a medical diagnosis and is a classification. Saying that this is an obese patient, but not saying that obese, hypertensive, like sort of like having a singular focus on your one-liner, always saying obese patient, or this patient has a history of violence as the starting point of everything. The challenge with care plans in Epic to me is that every time I open the patient's chart, at every single moment of interaction, that's what's coming into my forefront of my brain, right? Versus that one time that something happened. And so ultimately what this comes down to is smarter clinical decision support. I need the interventions at the right time for the right person for the right number of interactions. So when the front desk person checks them in, yes, they absolutely need to know. But maybe not every single time they open that patient's chart do they need to know that reminder every time. So a lot of this is being thoughtful about language and system design, but I think it's really about objectivity is the key piece here. Describe the actions, describe the behaviors, describe the next steps, and that usually will still communicate the same thing as sort of speaking. They were gesticulating wildly and were shouting and all these things. There is some element of truth to that, but then you won't really remember the clinical details at the end of the day, as we talked about. So I don't know what your thoughts are.
Yeah, I mean, it's a balancing act. You need to communicate accurate information to your colleagues and take care of the patient, and that's the purpose of the record. So, but you also want to not cause harm to the patient by including extraneous information that is ultimately harmful. So I agree. I think that it's a decision support adjustment. It's a timing thing. You need to include the right information to keep ourselves and our colleagues safe so we can continue to take care of more patients. Yeah, so yeah, go ahead. Yeah, exactly. So the recommendation is actually try not to include it. It's controversial, but try not to include a lot of your own opinions in the note at all, including lots of extra details. The problem with the positive language is if you include it in a way that is with one group of people and not with another group of people, that is also another form of stigmatization and bias. And so if ideally, it's actually better because the recommendation is chart less. Don't write as many words. Just chart what you need to communicate the information clearly in a way that is honest and non-stigmatizing. That's the goal. So really, people are saying write less, you know, which should be good news for us. So yeah.
I'll tell you a fun anecdote for me. Not fun, actually. Sorry. I had a patient who had all these positive charting markers in their note, and they were coming in for back pain, and then they would need a short supply of pain medicines of X, Y, or Z variety. Short course, they're very reasonable, just a few days, and you sort of every time say, okay. Turns out this patient had been going clinic to clinic with different IDs and getting in checked in under different names, and basically faking out the system, but being very pleasant, very positive, very likable. And I fell into that, and I discovered like 2 doctors later, oh, guess what? That patient, I saw him entering this other clinic with a different name, and I got so confused because I was actually thought this was this person. And so these sort of markers often, you know, we end up, whether we realize it or not, whether we want to or not, we want to see the best in people, but it sort of puts you in a position where you take down your defenses in a different way. So there's not really one direction that's necessarily better or worse. It's just recognizing there are directions, and we have to be thoughtful in all those cases. Paul, you had your hand up.
I guess my question is about the stigmatizing language or bias. Many of the examples are maybe within the subjective section of the note. I guess my question is, and part of what I'm thinking is, let's just take the word pressured speech under objective, and how good and I'm thinking of an expert in psychiatry that might have a very far more clinical impression of what that language means, as opposed to me in family medicine where I'm feeling a pressured speech. Anyway, where I'm moving to on this is the assessment, which is our judgment. Are there differences in the languages we use in your studies of these notes? Is there different language in our assessments than in that subjective section? And are experts more likely to be stigmatizing than novices in this area? Question.
Spoiler alert, there's a book for that. But I think that my experience, I'll speak to my experience just given time, is that I think the further we get in the career, the more set we are in our ways. And the same things you talked about are found in objective. Disheveled is another example. What does disheveled mean to you? Malodorous, what does that mean to you? One person's malodorous may be a different person's norm. You go to Europe and you'll have a different feeling about what malodorous does or doesn't mean, for example. And so the key pieces of it is every time, I mean, what we teach our students, every time you ask a question or write something down, know why you're writing it and what it's adding. Is it adding to this care for this patient today or in the future? If this person is coming in clearly intoxicated, inebriated, and you can smell alcohol, that provides value to me. But just saying they're malodorous and disheveled means a lot of things for a lot of people. And so I think what we're saying is, every word should have value and meaning, and it should be thoughtful about why it's there. I do agree that this persists through objective assessment and plan pieces in a note. And I would say that novices that are open to changing their ways, I'm not convinced that they're better or worse, but I think we have an opportunity as a teaching institution to open the conversation in a more formative way. It was opened up to me. Somebody saying, don't just say that's the 70-year-old diabetic in the next room. That's a 70-year-old person with a history of diabetes. That was taught to me when I was in medical school, and I've maintained that with myself here. Those practices, when the seed is planted, when the career is early, I think we'll see the fruits of that labor in the next 10, 20, 30, 40 years. So I know we're at time. I know we are getting an advertisement for our next grand round speaker here. So I'll turn it to you, Nina. I appreciate all your questions.
Thank you so much for that. I love the message that words matter. So thank you so much. Few things. If you want to claim your CME credit, text 105, I think 09 to 833-394-7078. That's in the chat. The QR code there is for your feedback. So thank you for submitting that. And we will be welcoming Dr. Chakuri to speak around climate change in medicine at our next grand round. So thank you everyone for attending.